So this is probably much more mundane topic than shock and balloon pumps and Pellas and all that exciting stuff that everyone enjoys doing. So I think they'll call up my slides here. I guess there they are. I will start with my disclosures here. I will say, so I consult for those companies. My real disclosure is I'm 100% radialist, and I believe everybody is existing in a state, if they're not already a radialist, of being a pre-state of becoming a radialist. The other disclosure is I did this talk last year and ran about 2 or 3 minutes over, and I've added like 20 slides, so I'm sure this is going to work out well. It'll be question and answer format. We still don't have buzzers, so please speak up, yell letters. It's totally anonymous. There's a big light in my face, so I can't see you. But it's good, and you can stop for questions at any time. So we'll just jump right in. The use of transradial access in PCI in the United States is approximately A, 10 to 15, B, 15 to 20, 25, 35, 40 to 50. So I hear a lot of Bs. And some C's, which is good. So this is just some reviews from NCDR. This is 2016, and there's always a time lag here. This looked at a couple 100,000 patients, and the rate you can see it's as of 2014 was about 25% of in elective cases. In the VA system, they track their outcomes similar, 32 versus 66 radial or femoral. So still about 1 out of 3 patients is getting PCI. This is data from 2013 older. I brought it because it was larger, about 3 million people. At that time in 2012, it was 16, so this rate is rising. But within the subgroups, it's important to know that it's still men, people in the Northeast, younger people age less than 75, and those that are not presenting with STEMI that tended to increase fastest. Outcomes, importantly, are not different, and this is huge data. Of course, there's some selection. It's not randomized data, but it's a huge quantity of data where there was huge differences in bleeding and vascular complications. So right now, this would probably be the right answer, although it's probably a little bit higher than this, like I said, a time lag. There may be, but I'm gonna focus on the cardiac stuff. I think that IR and things like that. There may be, but for right now, I'm just kind of sticking to the interventional angio, coronary angio, and coronary intervention. So how about in STEMI in the United States? Any thoughts here? So lower is what people seem to think, which is pretty close to correct. So this is also from NCDR, which looks at the rise. And you can see a relatively rapid rise, but starting in the low single digits to, in 2016, about 25%. Just to put it in context, this is from Validate Sweetheart, a European study. That was a bivalent heparin study, but just to show the numbers, and it was STEMI and non-STEMI, but 3,000 of the patients were STEMI patients, and it's 90% radial use overseas for STEMI. The answer here is 25%. Major bleeding post-PCI and ACS is associated with higher rates of which of the following? Death, MI, stroke, just death and MI but not stroke, or all of the above? I heard an A out there and a D. It's actually all of them. So this is old data, but again, large quantities, pooled data from several ACS trials, 30, 40,000 patients, huge odds ratio. This isn't radiofemoral. This is just if you bleed. And that's part of just kind of the common knowledge now that when you bleed with your PCI, you really have terrible outcomes, particularly if it's ACS bleeding. So all of the above. All of the following randomized controlled trials, TRTF for ACS, met their primary endpoint except Rival, STEMI radial, Rifle, Matrix, or all of these met their primary endpoint. I heard one E out there. So we'll jump into the kind of the didactic portion because it's just kind of grind through these trials. It will help answer that one question and subsequent questions. So, and a lot of this I figure you guys must know it's older now. The Rival study, pivotal trial, 7,000 patients, ACS and STEMI randomized to TRTF. The primary outcome was a NACE outcome, so MACE plus bleeding at 30 days. And as you can see, there was no difference in the primary outcome. And it's quoted by a lot of people as a reason that these are equal, but it's really just one piece of the puzzle. What's interesting here from this trial is when some of the subgroup analysis was looked at, specifically STEMI, there was a huge difference. Again, this was hypothesis generating, was randomized as such. but there was a 2% absolute risk reduction in STEMI mortality if the transradial route was taken. That led to a lot of other studies, smaller albeit. STEMI Radial 700 in Prague, the 4 centers, 2012, Radial versus femoral, all STEMI patients. Their primary endpoint was softer, was just bleeding and access site complications, but a dramatic reduction, so met its primary outcome. When you looked at the MACE in that trial, all the numbers tended to be lower with the radial septimi, but nothing significant. But mortality, really, interestingly, still almost, absolute reduction of 1%. Again, not powered for this. The NACE, so adding those bleeding and vascular complication to that, of course, was also positive because of the marked percentage difference in bleeding. Rifle trial, which is also kind of an important trial in this space, 1,000 patients, very highly experienced Italian centers, and they really enrolled everybody, no matter how sick they were, 500 each in each arm. Their primary outcome was NACE at 30 days and non-CABG-related bleeding, both of which were markedly reduced. The NACE outcome, you can see an 8% absolute risk reduction at 30 days. When you broke the components of the MACE, you could see, unlike other trials, it was driven by the hardest of endpoints, the death endpoint. And a lot of people thought this was just unbelievable, and it is remarkable, a 4% risk reduction, absolute risk reduction in death. But these were very, very, very sick patients, as you can see by the rates. Looking at the type of bleeding in that trial, it was all of the reduction was access site bleeding. So it's not like patients had bleeding elsewhere in the femoral arms. It was access site bleeding, whereas non-access was equal. The Matrix trial, obviously another pivotal trial, really changed some of the European guidelines. 8,400 patients, a complex randomization, as you know, transradial versus transfemoral in all ACS patients with sub-randomizations for bivalve versus heparin, and then a continued infusion looking at things like stent thrombosis. The primary endpoints were MACE and NACE, 2 co-primary endpoints. Now, technically, the MACE outcome was not significant by their predefined level of 0.025, but it was 0.03. But by their a priori defined definition, it wasn't. When the NACE, the net adverse, was calculated, it was markedly significant. That's obviously the bleeding and vascular. So the answer to this is Rival, which was kind of a neutral trial, but we gathered a lot of information from that. So, I didn't put Safari in that. It's the newest one. It's not published, but there's a lot of data out on it, so I thought I'd put this question in there. All of the following statements arising from the Safari STEMI trial are true except. So true except. It's important to read the questions. There was no mortality difference between TR-TF. There was less significant bleeding in the TR group compared with transfemoral. Door to balloon and lidocaine to balloon times were higher in the transradial group. Expected mortality was over 2 times what was observed in the trial. The trial was terminated for futility, or all of the above statements were true. I heard B is true except B. Okay, I think that's right. Surprisingly, but it's correct. So the Safari trial is presented in ACC 2019. The design is as here, similar. STEMI randomized to radial or femoral. The primary outcome was all-cause mortality at 30 days. They anticipated a 4% mortality in the femoral group, and that resulted in a power calculation of needing nearly 5,000 patients. Very well-treated patients, bivalve in the femoral arm, 90%, and 90+% on ticagrelor in both groups. What's interesting to note is that they weren't very sick MI patients. Maybe 1% to 2% in each group got LV support. Very little shock patients. The times were longer with radial access, and that's what's been borne out in other trials, so very consistent. So door to balloon, cath lab to balloon, and lidocaine to balloon. So lidocaine balloon is a good measure because at that point it's all the procedure and none of the systems prior, and they were all longer in the radial arm. But the mortalities were very low and equal. So based on this, the trial was stopped for futility. So I don't really know how much this adds. It is, again, one piece of the puzzle, and we'll see it's some cumulative data as well. What was surprising was that unlike every single other trial, there was no difference in any of the bleeding measures, which is just a little bit unbelievable. Maybe we know that bleeding is worse in sicker patients, and this was really a less sick STEMI group. So the answer is B. In the Rival trial, the primary outcome of 30-day NACE was not different between treatment groups. However, major bleeding was significantly lower in the group randomized to transradial access. So we know the primary outcome wasn't, but bleeding was less in the radial group. Oh, it's a semi-trip question. So it was all about definitions. So in their definitions, which was TIMI, non-cabbage major bleeding, which is a very strict definition, there were very low rates of bleeding and they were equal. But if you used acuity definitions of major bleeding, a marked reduction in bleeding with radial. So it's actually false, but that's not how the questions are going to be. So in the Matrix trial, a statistically significant benefit in MACE was seen regardless of center proportion of radial PCI, meaning what's the experience level of the center? Is it relevant or not? Was the benefit seen regardless? This is a big arguing point for the transfemoralists because if they're not at a high proportion center, they say, well, the Matrix trial didn't prove a benefit in a center like mine. And it's a true statement. The benefit was really localized to high center proportion, both for MACE and for NACE. In my eyes, it just means you should be moving to becoming a high proportion radial lab, but it is a true statement. This was also seen in the Rival results. The results were stratified by volume, and you can see the primary outcome here was really only positive in the high center use centers. So that's a false statement. It was not regardless of center volume. Female ACS patients experience a higher risk of severe bleeding and access site complications compared with male counterparts, but still derive significant reduction in these complications, as well as ischemic endpoints. Sounds pretty true. So a lot of sub-studies came from Matrix. One was the effect of gender. And as you can see here, this is complicated, but just the women transfemoral were in the dashed lines here. And you can see their rates are higher, but they still had significant reduction in both bleeding and MACE. So that's a true statement. In ACS patients, cumulative randomized data suggests a significant reduction in mortality at the cost of a slightly higher increase in CVA when transradial access is used compared to transfemoral access. So you're getting mortality saving, but at a slight cost of CVA. Is that true? Okay, we'll see. The answer is false, actually, and it's one of the things people believe, and there's kind of, I think we fall into anecdotes, but randomized data is important. Now, every case is different. Toxic shoulders, you're struggling for many, many minutes or longer, you can have problems, but in randomized data, that hasn't borne out. This is cumulative data published after Matrix concurrently death, 28% relative reduction, very far on the clearly non-overlapping unity radial better. Here, stroke 1.05, no different. With Safari, they published, or presented, I should say, the cumulative data, including their data, and there still was a significant reduction in mortality in STEMI patients. It just was a little bit muted, but it was still clear. So that's what I said when it's one piece of the puzzle, and the patients were heterogeneous in that they were less sick. So I don't think it moves the needle too much for me. Anyways, that's a false statement. It's not at the cost of higher CVA. 1-year results of the Matrix trial found a statistically significant reduction in both MACE and NACE in ACS patients undergoing TR and TF-PCI. True or false? So the 1-year results of Matrix. So I heard a false there. So that was published just a couple months ago in Lancet. Again, we saw it was borderline positive based on the definition initially at 30 days. At 1 year, it also at 0.05. So technically, numerically, it's very suggestive, but, and this is MACE, and this is NACE down here, was highly significant, 0.012. So technically that's false, but again, I think that there's even MACE benefit that's likely based on the numbers. So based on all this data, the current ACC, well, not based on it all, but the current ACC AHA guidelines recommendations for transradial access for PCI is, now this is just PCI, not ACS PCI. Recommendation 1, level A, 2A, level A, 2A, level evidence B, or not specified. D. C, 2A, level of evidence B. It's actually 2A, level of evidence A. There's a lot of evidence actually supporting it. for regular PCI in terms of reduction in vascular access site complications. It has a 2A, old recommendation. How about the 2013 guidelines for transradial access for STEMI patients now? Not mentioned, 2A level A, 2B level A, should be considered when feasible. Now again, this predates a lot of the trials, so it's kind of easy to understand that, but it also speaks to a question as to why these haven't been updated further. But so it's just D, it's in the text. It says should be considered when feasible, but procedural success with technique is dependent on operator experience, which is what the data showed to that point. What about ACC-AHA for just ACS patients, not STEMI? 1A, A, 2AA, 2B, B were not mentioned at all. Yeah, nobody thinks D. That's a clue. Not mentioned at all. You can. It's like a 300-page document. You can do a text word search for radial, and it comes up like once for some other like radial A line in the CCU or something like that. Not mentioned at all. What about across the pond? 2015 ESC guidelines on transradial access for ACS PCI is A. Yes, I think we all know this. So it's a level 1. I mean, it's kind of mind-boggling to me the discrepancy in these guidelines. It's, in no other area do I know it to exist to that degree. All right, moving on. A significant absolute reduction of in-hospital mortality in STEMI patients is derived from all of the following except TPA versus strepto, primary PCI versus lytics, door to balloon less than 60 versus more than 120, TR versus TF, or all result in significant decreased mortality. E. I bring this to just illustrate the point that TR versus TF has the same magnitude of benefit, and we'll see that. This was old, Gusto data, 1% reduction, TPA versus streptokinase, absolute reduction, mortality we're talking about. Here is primary PCI versus lytics. We got 2% more, absolute reduction in mortality. Obviously, it required a lot of systems. Door to balloons, yes, there is some loss, diminishing returns, but comparing 60 minutes to 120, certainly we still do know time is of the essence. And here's, this doesn't include some of the newer data, but it's still markedly relevant in that there's huge absolute reductions by something as simple as a strategy change. So just to put it in that context. Question, so all. Those most likely to benefit from transradial access are most likely to receive it. It's also a kind of a gimme question, but just to point it out, illogical answers that happen to be true. So that's called the risk treatment paradox. It's something I'm sure most of you have heard of. This is just a quantitative illustration of that. This is a study of 18,000 patients with they stratified people by expected predicted bleeding risk, low, medium, and high. And the black bar is femoral and the gray bar is radial. So this is increasing levels of risk, predicted risk of bleeding, and you can see there was increasing use of transfemoral in those patients. So we're doing TR, and I think many of you guys might find that in your practice. We are susceptible to it. We see a 40-year-old, it's relatively healthy. Oh, let's just go radial. That's a person who's going to be fine either way. It's really the 80-year-old, small body weight, CKD woman, plus or minus bypass surgery, who's going to have more bleeding risk or ACS presentation. Predictors of unsuccessful transradial PCI include all of the following except obesity, short stature, older age, female gender, shock, bypass, all of the above. So which one doesn't predict failure? So it's actually A. I think I might have deleted one slide here. So we know people older than 75 have higher risks of failure for really subclavian tortuosity is the main reason. Prior CABG is a reason to fail, inability to get grafts. Short stature and short height of ascending aorta makes successful catheterization more difficult. This just shows the relationship between height and success. So the taller people are, or height and failure, the taller people are, the less failure there is. And this is a study that looked at a combination of factors, female sex, bypass, and shock as numerical points, 1, 2, or 4 for those, and the cumulative score of how many of those that a patient had, clear relationship with failure of radial PCI. So obesity really doesn't affect your probability of success. It's actually one of the reasons we often do it. Proven strategies to reduce RAO, radial artery occlusion after transradial cath, include all of the following except smaller sheath. So which one doesn't reduce RAO? Smaller sheath, therapeutic anticoagulation, 50 units per kg, high-dose anticoagulation, 100 units per kg, patent hemostasis, ipsilateral ulnar compression for an hour with sheath removal, post-procedural NOx times 4 weeks, avoidance of repeated access. So it's supposed to be all of the above reduce it. So C, you guys think C does not reduce risk of RAO. We'll get into that. So sheath size, pretty straightforward. You know, we've known this for a long time. If you put a bigger sheath in, there's more intimal damage and likely for occlusion and thrombosis. You can see a drop-off at 6.5. Technology has improved, obviously, slender sheaths where the inner diameters are maintained at 6 French and the outer diameter is maintained at a 5 French by making the wall thinner. That's allowed us to reduce RAO significantly. Anticoagulation, I'm shocked by a lot of people, you know, our fellows come and they tell us what they did as diagnostic fellows. A lot of labs still use partial dose heparin. This was looked at in a randomized trial. Dramatic reduction in RAO with therapeutic, 50 units per kg, up to a max of 500 in that trial. It's important to note that other antithrombotics are sufficient, but Coumadin and probably NOACs are not. So when patients are on those agents and they need caths, they should be giving therapeutic heparin to reduce RAO, you know, taking their whole context in. What about this high dose concept? Well, this was recently published, the Spirit of Artemis study, which looked at high versus standard dose by the same group. They randomized 3,100 patients to 50, as I said, or 100. That 100 was given 50 at the time of sheath insertion and 50 at removal. These were non-PCI patients because those got full anticoagulation regardless. And there was a significant drop in RAO risk. So with 100 units, 3%. So this is one trial, very well performed, but there's even further reductions in RAO if you give a dose of heparin prior to removal. It's not quite yet our practice, but I think it probably will be ultimately. What about patent hemostasis? This is, we know this to help as well. This is pneumatic compression where they measured with a manometer, the pressure of occlusion. They had 2 groups, one that was at near the map, one was twice the map, and the occlusive pressure group had much higher risks of radial artery occlusion. We use a reverse Barbeau test, so with the band on, we'll occlude the ulnar to make sure that there's still patent flow as manifested by a waveform there. Patent hemostasis reduces both early and persistent occlusion. What about ipsilateral ulnar compression? That same group, Dr. Pancholi and others did the Prophet 2 trial. They looked at ipsilateral ulnar compression for 1 hour at the time of sheath removal, and there were dramatic reductions. So, you know, I think a lot of labs aren't doing patent hemostasis properly, so that's probably the first step, but this is kind of the next level of reducing this, you know, important complication. Repeated use, we know for sure that when someone's had a repeated use, their diameters are smaller and there's more reduction. So it's really enoxaparin has not been ever studied or proven to reduce radial artery occlusion. What about radiation exposure? Radiation exposure is higher with transradial procedures for ACS compared with transfemoral procedures, regardless of operator experience. Right, and that is true. So it's statistically higher at low operators, but it's numerically higher for all this is radial by center and operator. You can see radial operators get more radiation. That was also shown in the RAD matrix study, kind of sub-study of the matrix trial. They saw statistically less radiation. This is the femoral group here. This is a radial group at the thorax. These were kind of equal, although again, numerically against radial. So that's a true statement. So it's important to understand that while the overall radiation exposure has decreased, the difference in radiation exposure between transradial and transfemoral angio and PCI over time on average has remained unchanged. So the gap has stayed the same even though the total amounts for both have gone down. True or false? So it's actually false. This was a meta-analysis and just shows that with proficiency, this risk goes down with radial operators. This is a meta-analysis, looked at a lot of studies, and you can see these are kind of complex plot here, but this was the average gap, basically, of additional radiation across time, so from the 90s to the 2006. So that's narrowing. This is another representation of that. Low volume users had 13% difference. High volume users had 7% difference. So the best practices are out there. This is a published document from a couple of years ago. Avoid cine of the upper arm or fluoro of the upper arm, the wire. We do fluorosave. And I put that in there to say that usually good operators, good radiation hygiene operators are good operators, whether they're radial or femoral. So if you're a low radiation femoral operator, you'll probably be a low radial operator as well. So that's actually false. The learning curve for transradial and stable patients flattens out after approximately 50 to 100, 150, 200, and 250. It's about 100. So you can see there's a dramatic decrease in fluoroscopy time that kind of levels off right around the 50 to 100 range. This just shows that contrast and fluoro time also. I'm kind of going a little bit faster since I'm behind. To that end, there's published guidelines of how to incorporate volume into practice. This is in the ESC guidelines. On neurointervention, you start with easy patients, planned PCIs, then all stable patients, then all PCIs, ad hoc, then non-STEMI and STEMI. And it doesn't take that long to get to a point where you're an experienced operator and then can reap those benefits as seen by the randomized trials. Right radial access is associated with less fluoroscopy time and provides more operator comfort as compared to left radial access. So the Talent study showed that actually there was less radiation with the left radial. It behaves more like femoral, and we're more experienced with that. In the RAD matrix trial, however, they were equal between right and left. Right is in orange and left is in blue. There was a meta-analysis looking at that, and it's pretty clear that both fluoroscopy, here's the zero line here, left radial had less fluoro time and less contrast use. And again, it's a function of experience, and the left radial behaves. So we do that in our tougher cases. We'll use left radial for those purposes. Comfort, on the other hand, is clearly more favorable from the right, as most of you probably know who are in the lab. So that's false, because it's not more comfort, it's less comfort. So in CABG patients, transradial access for coronary angiography is associated with all of the following except higher contrast, more procedure time, more fluoro time, increased operator radiation exposure associated with all of the above. So there's really one trial here. It was a small, randomized trial, that is. It was a very small sample size, radial versus femoral randomized in CABG patients. It's important, and all of those things were worse with radial, but it was a very small sample size. No offense to those out there, but the fellow was the first operator for 3 full minutes. And the CABG anatomy was known more in the transfemoral than transradial, which is probably the most important thing. In CABG patients, transradial, so this is the answer, associated with all the above. In matrix trial, the incidence of AKI was greater in the group randomized to transfemoral access, so more AKI in the transfemoral group. I guess that's a trick question too. So this was published a couple of years ago. This is radial in the blue and femoral in the red, and there was 2% less risk of AKI. That was defined as either 25% increase or 0.5 absolute increase. You can see marked reduction. This is a priori defined. What was most important, I think, from this is if you looked at the subgroups who benefited in terms of AKI risk, it was those who already had CKD, those that were older, those that were sicker, Killip class, and those at higher Moran score, so predictive risk of CIN. So again, it's the opposite of that treatment paradox. It's the symptomatic, the sicker patients rather that had more of a benefit. So that's actually true. A lot of people, I think, don't know that. Both TR access and ultrasound guided access reduce the risk of NACE in elective patients undergoing coronary angiography intervention. So TR and ultrasound guided reduce NACE. So this was just published or presented in EuroPCR, the SURF trial. Excuse me. 1,400 patients randomized both to transfemoral, transradial, then sub-randomized to standard access or ultrasound access. And what they found was that in those access by access site, radial produced less NACE, significantly less NACE, 2%. But by ultrasound guidance, there wasn't a difference measured. What they did find was that there was less time to access and less attempts with ultrasound, but it did not change NACE. It's false, so it's just TR access, not ultrasound guidance. So the incremental prognostic value of guideline-directed medical transradial, here's the There's no question in there. I'll jump over that. Well, here was the question. So establishing a system-based strategy to increase TR-PCI for STEMI has been proven to result in incremental improvements above mortality. So can we implement these things? Have we proven that this actually works if you implement it into a system? And that was done at Duke. They added GDMT, transradial PCI, and door-to-balloon. And if you got 2 or 3 of these metrics, you had much significant risk of everything, including death. So almost done here. Hospital costs, primarily by way of reduced length of stay, are significantly reduced when compared to transradial transfemoral. That's true. I think most of you know this is length of stay by bleeding risk. All patients had about a 0.38, but if you looked at by bleeding risk, those with the highest bleeding risk almost stayed an entire day less, which saves a lot of money. Up 800 on average, 1,600 in the high-risk patients. In the UK, they presented big data on the same thing. They showed a 250-pound reduction in cost, 200 of which was based on hospital length of stay being reduced. So very, very important to the beam counters. Unless they've suffered a complication, patients prefer the same access for subsequent procedures. So if femoral patient, even if they didn't suffer a complication, so if they didn't suffer a complication, did they still prefer a femoral access? So, we know quality of life measures are much better with transradial, all measures compared to transfemoral. But interestingly, from Rival, they asked patients, would you prefer the same route for a subsequent case? And only 50%, of course 50% didn't have complications, but 50% said the same, whereas 90% of the So it's a clear measures that people prefer this, and I don't think that our practice speaks differently to that. So one last question. If you or a loved one, I'm going to ask for hands on this one. If you or a loved one was suffering from a STEMI, which vascular access would you prefer? A, radial, you can raise your hand. Okay, at least you guys are awake. So somebody's raising their hand. Yeah, it's about maybe 80% in there. Femoral, should I say femoral, or are other people just abstaining? Anyone prefer femoral? All right, 3. Okay. That does not represent what people are getting in America, but that's cool. So anyways, thanks a lot. Sorry I went over a little bit, although Jason went over too. So.